Dr. Yoli.
Well, most of you will know me as a haematologist, so hopefully by the mid sort of point of this talk, you'll realise why I'm interested in prostate cancer per se, as opposed to haematology. But you'll also know what mechanisms are involved in hematopoiesis and hopefully then the metastatic process that's involved in prostate cancer. So I like to put a few slides up with cells on, and this is probably the only one that you're actually going to see, the actual boys in action. So here you can see confocal microscopy of the prostate cancer cells, which are actually an adenocarcinoma, and you can see them with this sort of nuclear staining in the centre. They're quite active. But it's these boys at the right-hand side that are actually the metastatic cells, which now have the ability to form these protrusions and move from the adenocarcinoma. And that's where it gets kind of dangerous for anybody with prostate cancer. So some of the statistics then, there's been around 40,000 new cases in the UK alone of prostate cancer. You've obviously an increased incidence whenever you go beyond the age of 50. And the diagnosis is usually at an advanced stage, and that's because the actual clinical symptoms are very difficult to detect until it gets to a metastatic stage. The 5-year overall survival rates are still very poor at in around 30%, and that is even with the advanced treatment strategies that we now have, which are androgen deprivation therapy and anti-androgens, which are given orally. But the main thing is that bone metastasis is the main contributing factor to the actual patient demise. And this is because whenever the tumour gets to the bone itself, it either forms a lytic pathway where it actually eats the inside of the bone effectively away, or it forms this sclerotic pathway which goes the other way, and there's too much bone formation, which doesn't allow bone to have the usual aspects that it has in hematopoiesis itself, and also in immune surveillance within the person. So prostate cancer itself, as you know, the cells undergo this process of transformation. They then form this pre-malignant niche where they actually affect the niche surrounding it, which then in turn give growth factors and stromal factors back to the cancer cells themselves. And then they effectively become stromal independent cells whenever they get enough aberrations accumulated. And at that point, they're called metastatic because they can then move out of the niche without any dependence on the stromal surface that surrounds it. And prostate cancer specifically metastasizes to bone. And the reason for that is that they take on this osteomimicry process. And in a way, they're effectively putting out cell signatures where the body thinks that these are osteoblast cells from the bone itself. And they start producing things like osteocalcin, bone sialoprotein, TGF-beta and BMP, endothelin-1, so that the cells within the bone marrow then see these cells that are invading as self, and they aren't destroyed and eliminated from the bone marrow. So this is a specific process where the bone marrow then sees these cells as not being foreign to that actual organ. And CCN genes and proteins are involved in the bone marrow microenvironment. They're involved in mesenchymal stem cell differentiation, and this is in CCN2 and CCN3 in bone remodeling of osteoblasts, the bone forming cells, and osteoclasts, which are the bone resorbing cells. They're also involved in endothelial stem cell replication, and this is formation of your vasculature and your lymphatic system. And then the bit that I'm interested in, which is hematopoietic stem cells, involved in hematopoiesis and formation of all your blood cells then within your circulation. And they're involved in a number of things, including the stem cell renewal, and then the differentiation capacity, and then the matrix remodeling within the bone marrow itself. So there are 5 members of the CCN family. CCN 1, 2 and 3 are well characterized. 4, 5 and 6 are more recently identified and less well characterized. But what it transpires is 1 and 2 are seen as being pro-proliferative and pro-angiogenic, where CCN3 and CCN5 are seen as tumour suppressor genes within the family. And they have 4 domain structures. They have a signal peptide, and then this insulin-like growth factor binding domain, called Miliband type C repeat, a thrombus bonding type 1 domain, and a cysteine-rich carboxyl terminal. They also have this hinge region within the central zone, which can be specifically cleaved, and then the carboxyl terminal can translocate to the nucleus and act as a transcriptional factor. And in this manner, they're seen as matricellular proteins because they interact at the matrix cell surface by binding integrins, bone morphogenic proteins, and TGF-beta signaling proteins. And they can also act as transcription factors by acting downstream within the nucleus on a subset of genes specific to that particular molecule. So this just shows you the stem cell signalling pathways that they're involved in, and because they're involved in stem cell signaling, they have been associated with the formation of a number of tumours. For instance, CCN proteins can sequester a number of ligands for the TGF-beta, bone morphogenic protein, Notch or Wnt signalling pathway. CCN1 and 2 can actually activate TGF-beta and BMP receptor signalling themselves. And specific to that, CCN1 and CCN2 are shown to upregulate expression of osteoprogerin, alkaline phosphatase, and osteocalcin downstream of them. And that's particularly important then for prostate cancer whenever we look at that in more detail. It's previously been shown that CCN3 is involved in this prostate cancer development pathway, and this was published in 2001. This is a non-malignant cell line, which is a precancerous stage, and you can see CCN3 is not readily detectable by Brown staining. The early metastatic cells have a high upregulation of CCN3, and then as the tumour gets to a highly metastatic stage, CCN3 is downregulated. And you can see this when you then look at the primary samples. So in benign prostate hyperplasia, you can see CCN3 is at the secretory surface within the prostate gland itself in this sort of pre-malignant phase. And then in low-grade adenocarcinoma, CCN3 expression is high and then down-regulated whenever you get highly metastatic cancers. And this is consistent with the PIN model that is associated with this pre-intrathelial neoplasia associated with prostate cancer itself. So we had a look at the model then for prostate cancer itself from this low metastatic potential LM cap cell line through to the DU145 and PC3 cells, which have this highly metastatic potential. In addition to that, the low metastatic potential cells are hormone responsive, and the highly metastatic cells are hormone insensitive, which shows you that they will not respond to androgen therapy, which is the current treatment strategy on the market. And from this you can see from our real-time PCR that was conducted on these that CCN1 and 2 are highly upregulated in the highly metastatic cell lines, and CCN3 is subsequently downregulated whenever you get to the highly metastatic potential, which is consistent with the primary tumour data. So what we've done is use siRNA, which is directed against these genes, and we've done a scratch wound test where you draw the pipette tip across the cell monolayer at t equals 0, and you take a measurement. You then go back 24 hours later, and the control cells will have migrated across the wound pretty much to close it up, whereas CCN1 knockdown cells, where CCN1 gene expression has been knocked down, you can see is retarded. So whenever we look at this across the board then with CCN1 and CCN2, we can see that knockdown of CCN1 or 2 inhibits this migratory response across the wound. And similarly, whenever we use the Roche Excelligent system, so this is a modified assay from the Boyden chamber assay where the cells are migrating through a plate to a lower chamber of fetal calcium supplemented media. You can see that CCN1 and CCN2 knockdown both significantly retard PC3 cell migration to fetal calcium. We then went to have a look at the stem cell renewal capacity of these cells using the knockdown approach. And you can see that dramatically in comparison to control cells here on the left-hand side, CCN1 knockdown significantly inhibits then the renewal capacity of these metastatic cancer cells. Not so much then for the CCN2 knockdown cells, and non-targeting was not significantly different from control. We then went to look at CD44 expression, and the reason for that is that CD44 is a marker of cell motility and invasion in prostate cancer. It is also the main marker for stem cell reinitiation capacity of secondary tumours in prostate cancer. And as you can see by this graph, CCN1 specifically and significantly alters CD44 expression within the metastatic cell model. So on another strand, we decided to have a look then at the bone remodeling side, and if CCN1 or 2 could actually affect the balance of bone formation and bone lysis within the bone marrow. And usually under normal circumstances, you have the balance of this rank ligand and osteoprotegrin within the microenvironment, which gives you the balance in normal circumstances of bone resorption through osteoclasts and bone formation by osteoblasts. However, whenever osteoprotegrin isn't present, rank ligand binds to the osteoclast and allows bone resorption to pursue. Whenever osteoprotegrin is present, it mops up the rank ligand activity and allows osteoclast to undergo apoptosis, and then osteoblasts will allow bone formation to pursue. And we have found then whenever CCN1 is knocked down, we're actually increasing the amount of osteoprotegrin which are allowed within that microenvironment. So in effect, increased CCN1 levels will decrease osteoprotegrin expression and allow the osteolytic pathway to pursue and overtake that bone forming pathway. So in summary, hopefully I've shown you that CCN proteins are key modulators within the bone marrow microenvironment, and both CCN1 and 2 are involved in the migratory process of these metastatic prostate cancer cells. We can also see from this that CCN1 in specific drives the stem cell renewal capacity of the metastatic cells, and this is in a process involving CD44 expression, which may allow the reformation then of resistant tumours in vivo or in vitro. We can also see that CCN1 modulates expression of osteoprotegrin, which could contribute then to the lytic bone disease seen within metastatic prostate cancer, leading to the demise of patients. So this is just the acknowledgement slide for everybody who's been involved in this, which is Daniel, Nina, George and Thomas at present. We also have collaborations with Bristol Urological Institute and University of Liverpool, and then Andrew Lease across in Canada. And that's it, thank you.
Questions for Lynn?
I enjoyed your talk. siRNA has been very difficult to use clinically. So have you thought about how this might develop? Are there any specific drugs that might be in development?
Yeah, the next strand is to actually do the drug screening profile. Once we can actually get the pathways pinned down, so the open array will be used to identify the pathways at a cellular level, and then we'll do the drug screening approach to actually identify the candidate drugs that could be utilised to take forward on that. So that would be the sort of approach that we're going to take from here.